your middle. Can you still hear me, guys? Okay, good. So what you would do is you would email your TA, and then they would review it with you. So in terms of the two questions, just going over the right answers for the midterm, just email like your specific TA. So the TA that you have for your tutorial, and then they'll schedule like a Zoom call with you, and then go over the midterm with you. I think it's important if you have time just to go through it, and then that way you get a better idea of what you did wrong. I've had some people email me, and I find that sometimes people were confused as to like what things to particularly study, or other things is that they feel as though they knew it a lot more than they thought or they knew it less than they thought they did. Final isn't question from Kayla. No, final isn't cumulative. So I think it's anyway. So back to what my point was is that I think it's important when you're studying, not only for this course but for all courses, to challenge yourself. So don't just read through the lectures one by one and then sort of memorize, because it doesn't consolidate the information for you as well as it would be if you challenge yourself. Like ask yourself questions, make cue cards. I like to do study notes. That's what I did, because it forces you to like sort of like group things together. Try to get yourself to ask questions about the material that you are studying, because it leads to better memorization. Yep, Mohammed, the lectures are recorded, all of them, yeah. Any other questions about the midterm? The midterm is the difficulty of what the other midterm and the final would be. So now you have a better idea of what sort of questions. I had like 1,000 emails about like what diagrams. Now you get an idea that the diagrams are more specifically to detail things that we had particularly talked about. Any other questions about the midterm? Plus. Natalie, what does plus mean? Minus. What kind of dog? Okay. Cute. Do you want to present your screen and then we can all look at the dog? Or will that screw up my presentation? Oh, wow. I have a parrot. You have a dog. Yeah, my parrot talks, yeah. Okay. Well, we all have animals. Look at that. Maybe one day I'll do a lecture from my house, and then you guys can like hear him. Someone's gonna write, "I have a kid." Oh. We have 74 people in the chat room right now. Usually it's at about 100. So I don't know if I should get started or if I should wait. Jeremiah, I'm sorry about your fish. He's in a better place. And the experiences that you had with him will never die. Just think of the positives. Oh. Just question for you guys. Are the other group chats, like in your other classes, as good as this one? Perfect. Because I found out that they record these, so that like they check like our chat logs. Yep. Yep. If I say Charlie, someone's on the phone, the faculty is on, and then everyone goes silent. Code word Charlie. Do you watch us? I didn't watch you guys. But then it sends like a notification if there's like any suspicious behavior, like if you guys are being suspect. It'll send like notifications, and then the faculty reviews it. Yeah, no red sus, always red. We're at 80. I wonder if maybe because it's recorded, most people just want to just watch it after, maybe. So I'll get started. Is that okay if I get started, everyone? Okay. So before we continue on with the new stuff, was there any specific questions in relation to the asynchronous lecture? It was pretty straightforward. And it's talking about now the connection between the neurons. So last week we talked about the functional unit, the neuron, and the different components of the neuron, what a typical one looks like, and what the different variations are. Today's lecture, or this week's module, is discussing the synapse. And it's really important because it's the synapse that allows sort of the neurological system to integrate information. And we'll get into how it does that. We left off the asynchronous lecture right here, okay? And so what that means is that we have excitatory and inhibitory postsynaptic potentials that can occur at either the dendrites or you're still on the outline. Can you see, like I'm switching. Can you guys see it? Me switching? Okay. Let's try this again. Okay, stop presenting. Present. Window. How about now? Perfect. Okay. So in the asynchronous lecture, we learned about the different excitatory and inhibitory postsynaptic potentials. So we have those local potentials, or small stimuli that can be either negative or positive, or cause depolarization or hyperpolarization. And it's the summation of all those little local potentials at the dendrites and the soma, and then we also learned about at the axon terminals, that will sort of allow or inhibit an action potential from being created. On the midterm, the short answer question in terms of how these local potentials summate was these two options, spatial and temporal summation. So you've seen this before and we're tested on it. And so I just wanted to review that it's through the general summation of these local potentials, either temporally or spatially, that we get a buildup of a depolarization, and then we get to that threshold to start an action potential. And then an action potential is an all or none response. So if enough of the addition leads to a decrease of negative 15 millivolts in the membrane potential, the first voltage gated channels will fire, and then we get an action potential that is an all-in response. So once it begins, it doesn't stop, and that continues down through the axon to the axon terminals. Perfect. So spatial and temporal summation are how the different potentials can add up. And if you can recall from this diagram, we get sort of a visual depiction of that. So if local potentials add up temporally, it means that we have a buildup of potential because local potentials are happening in the same spot in quick succession. So in here, we see a depolarization, and there's an additive effect of a depolarization in quick succession. Whereas with spatial summation, we have a accumulation of multiple depolarizations of local potentials happening at the same time in different areas. And so what happens in real life at a neuron is that both of these are occurring at the same time. So in terms of the summation of our local potentials, either excitatory or inhibitory postsynaptic potentials, they're all accumulating at the same time in the same area and are adding up in a process called general summation. And if the way that they add up leads to a decrease in the membrane potential, a depolarization of negative 15 millivolts, then we get an action potential. And then this is just another diagram to depict that as well. So hopefully now that we've talked about it both in the midterm and now, you get a better idea of how the neuron is able to integrate information. Because remember, we have a neuron with a whole bunch of dendrites at the around the cell body, right? Now, those dendrites are going to be sort of stimulated by potentially a large number of other neurons that are attaching or receptors. So we have multiple stimuli happening at once. And so through general summation, we say that the neurons are like a computer in that they're able to integrate the information. They receive the information in the form of local potentials. They integrate it. So let's say there is enough excitatory. That means we're going to have a depolarization. Or maybe there's more inhibitory. So that means an action potential isn't going to happen. It's integrating that information that allows our neurons to sort of respond to the different stimuli that are being presented to the dendrites. If there's enough of a stimulus, we get a transmission of information. That's through the form of an action potential. And then we transfer that information through the synapse, which was the topic of this week's module. So it's the integration of the excitatory and inhibitory synaptic potentials. Does that make sense for everyone? So it's not like a neurological system is a computer in a sense, but it is a way to process a whole bunch of information because of all the different connections that influence each other. Is everyone okay? Okay, cool. So one important, or the most important aspect of how we transfer information is through the use of neurotransmitters or neuromodulators. Now, these are molecules that are being created at the soma of our neuron, or the cell body of our neuron. They're packaged, and when in response to an action potential, the neuron releases neurotransmitters so that they can float across the synapse, interact with another neuron or another cell membrane, like a muscle membrane. Okay? So it's these chemicals, neurotransmitters and neuromodulators, that are used to transfer the information from one cell to another. Now, these molecules can be the same. What defines them as either a neurotransmitter or a neuromodulator is the area in which they're released. So a chemical is described as a neurotransmitter when it's released by a presynaptic neuron. So it's released by a neuron into the synaptic cleft. So it is released at the axon terminals and it interacts with the dendrites of another neuron. So those neurotransmitters will float across the synapse and interact either directly or indirectly with receptors on the postsynaptic membrane or the postsynaptic neuron. And we'll get into what indirect or direct means in the next couple slides. If these chemicals are released into the extracellular fluid, so instead of being released to interact with another neuron or a postsynaptic neuron, if they're released into like open space, they have an opportunity now to float and interact with multiple neurons. And that's called being a neuromodulator. So depending on where that chemical is released, it's either called a neurotransmitter or a neuromodulator. If it's released into the synapse, typically those chemicals will only interact with the postsynaptic neuron. If it's released into the extracellular fluid, it'll diffuse the chemical and then have an ability to spread and interact with multiple different neurons. It just takes a longer amount of time. And so what we see with neuromodulators is they have more of a systemic effect, whereas neurotransmitters are more of a direct effect. And when you're given drugs, and we'll learn about drugs at the end of the lecture, drugs that you would give specifically for neurological diseases, for example, they mimic either neurotransmitters or neuromodulators, or they block the receptors for those chemicals. So that way it stops their function. So here we have a diagram depicting the difference between a neurotransmitter and a neuromodulator. We have an axon terminal of a presynaptic neuron. Here we have glutamate being released into the synaptic cleft. So would that be a neurotransmitter or would that be a neuromodulator? In this case, looking at green. Yeah, and that's because it's being released into the synaptic cleft. And then that would mean that substance P in this case is being released into the extracellular fluid, and that would make it what? That would make substance P in this diagram a neuromodulator. Yeah, perfect. So when the neurotransmitters or the neuromodulators interact with another neuron or a postsynaptic neuron, they can either act directly or indirectly, okay? And so we learned that typically when we have receptors, those receptors will bind to only a specific chemical or a ligand-gated channel, right? They'll only bind to a specific chemical or specific molecule. That molecule is a neurotransmitter or a neuromodulator. If those chemicals act directly, hi Heather, yep. It's so the recorded, so I have a question. Will you upload the recorded lecture to Canvas after? I've been putting it on a YouTube link, so that way you can watch it. Have you seen, Heather, did you see the other lectures? Like previously recorded ones? Heather? Because the other lectures were recorded, so hopefully you looked at them for the midterm. She's not responding. Heather. Okay, well, good luck, Heather. If you have any questions, please email me after. When the neurotransmitter binds to a specific receptor, it's like a lock and key mechanism. If that receptor is a channel, so when the chemical or the neurotransmitter binds to the receptor and it opens a channel, like it's a one-to-one ratio, it's one structure, that's called direct activation. So when the receptor is specifically an ion channel, it's called ionotropic, and it's called direct activation of a channel because it's very fast. If we have a situation where the neurotransmitter or neuromodulator binds with a receptor, and then that receptor releases a protein, so it's not a direct channel opening, that's called metabotropic. And what happens is that binding of the neurotransmitter with the receptor causes a release of a G protein, or what's called a protein, into the cell, and then it has an opportunity to interact with multiple different structures. That's called metabotropic or indirect activation. And the reason why there's two different options is because we can have fast-acting and slow-acting neurotransmitters, or fast-acting and slow-acting types of local potentials. And it allows our neurological system to either respond quickly to certain things or slower to other types of stimuli. So let's review that. For example, fast-acting are those neurotransmitters that lead to direct activation of a channel, and that will typically cause that transmission takes about 1,000th of a second, because we have a neurotransmitter binding with a channel, right? And then that channel opens immediately. So it's a very, very quick sort of situation. And examples of those that we're going to learn about are acetylcholine, glutamate, and GABA. Those are fast-acting neurotransmitters. Slow-acting neurotransmitters are going to be those receptors that cause a release of a protein that have an opportunity to float into the neuron and then interact with multiple different areas. That's called slow-acting. And the reason why it's slow is because it doesn't directly open a channel. It has to have a release of a protein that has to float and start interacting with different structures. This typically takes 1/10 of a second. So we can see that there's sort of like 100% sort of decrease in the time it would take to transmit that information. The reason why your body would do that, though, is because instead of having one neurotransmitter opening one channel, with indirect activation, we have one neurotransmitter releasing one protein that can interact with like 10 to 20 different channels. So it's a much larger sort of stimulus. However, it just takes longer. And so it's that interplay that allows your neurological system to respond to different stimuli. So examples of slow-acting neurotransmitters would be things like amines, like dopamine, epinephrine, serotonin, and substance P that we talked about in the last couple slides. We have a question from Magdalena. Does the direct and indirect activation apply to both? Yeah, so because remember, the neurotransmitters and neuromodulators can be the same chemical. What defines something as a neuromodulator or a neurotransmitter is where it's being released. And so the receptors are going to be specific to whatever chemical. Right? And so it's the receptor that is going to dictate whether or not it's a fast-acting or slow-acting transmission. So, like, we're going to learn it for about drugs. There's situations where you can have like different types of the same or different receptors that bind the same neurotransmitter. And so we have, for example, like epinephrine will turn off digestion, but then turn on like fight or flight. So we have the same neurotransmitter that when it interacts with different types of receptors, it causes either inhibition or excitation. And so that's why we can have one neurotransmitter having sort of multiple effects in different areas. Hopefully that makes sense. Does it? It's the receptor that dictates what the sort of effect is. We said that direct activation of channels takes about 1,000th of a second. Indirect, so the protein release, takes about 1/10 of a second. When something is released as a neuromodulator and it has an opportunity to float and hit different neurons, that can take from minutes to seconds. And then the effects of that, because it diffuses out into the body, can last from minutes to days. So we see down the 3 different options on how each takes longer or can take less time and how it affects sort of the transmission. Quick transmission results in a sort of smaller effect, whereas a longer amount of transition takes longer but can have a much larger effect. An example of a neuromodulator would be substance P. Now, substance P is a neuropeptide or a neuromodulator that is released into the cytosol in response to pain. And so what we see is that, and that's why I'm bringing it up, because substance P is a neuromodulator, it makes an area sensitive to, like, so here's a question. Think about when has anyone got a cut or like bumped or gotten a bruise or something on their leg or their arm or their body? The area around it is very sensitive. And that's as a result of substance P, because it makes everything else in that area sensitive to pain. Substance P is sort of implicated as sort of the result of, or maybe the cause of, a lot of pathological pain syndromes. Has anyone ever heard of fibromyalgia as an example of a pain syndrome? Fibromyalgia is a sensitivity to pain. So with people that are affected with fibromyalgia, they have joint pain and tenderness in response to normal stimuli. So me touching my skin, I don't feel that as pain, I just feel that as touch. Whereas because their body is sensitive, they would feel that as painful. And that's as a result of, they think, a buildup of substance P that makes the whole body sensitive. Jessica has a question. Why does it do that? Oh, so the reason why you would want an area that you injured to be sensitive is because you don't want to like screw with it, right? So think about animals, right? They cut themselves, they have a tick bite or something. They don't want to keep like irritating the area. So a lot of this stuff that we see is as a result of sort of evolution. Cool. Okay. So like I said, what dictates the sort of result of a neurotransmitter binding is the specific receptor itself. So it's the synaptic receptors that are going to dictate what the effect of the binding of that neurotransmitter or neuromodulator will do, okay? And so what the receptors are typically named as they're named by the neurotransmitter that they specifically bind. So let's make up an example of a neurotransmitter. Epinephrine. So you can have epinephrine alpha receptors, epinephrine beta receptors, epinephrine gamma receptors. So they're all just different versions of receptors that specifically bind the same molecule. And then each of those would have a different effect. Remember, when we have the neurotransmitter or neuromodulator binding to a receptor, we can produce either a direct or indirect activation. Direct activation is that if the receptor is a channel, leads to a transmission within a thousandth of a second. Whereas if we have an indirect activation, we have that receptor causing the release of a protein that will go on into the cell body or into the neuron and either interact with a whole bunch of different channels or interact with different cellular processes for metabolism. No, so typically, because it's a question from Matt, he said, can receptors receive different neurotransmitters or can they be, or are they specific? Well, because it's like a lock and key. So if you look at it under a microscope, like the molecule is a shape. And then so the receptor fits only that shape. And when we make synthetic drugs, we find out chemicals that are kind of similar. So they'll like fit into the receptor. So I'm sure there's situations where like things will cross, sort of contaminate, but typically a receptor is specifically as a lock and key mechanism for just one molecule. And that molecule will be called a neurotransmitter or a neuromodulator. So based on what we just learned, there are 3 different options once we have that neurotransmitter binding to a receptor. If we have an ionotropic or direct activation, neurotransmitter binds, we cause an opening of a channel and we get a local potential. That's called fast synaptic transmission. If we have the release of a protein, that's metabotropic or indirect activation, and that protein can go in and then float on the inside and then open 10 different channels. So it has a larger effect, it just takes more time. So that's called slow synaptic transmission. And then the third option is if that protein in an indirect activation floats around, it may not have to interact with different channels. It may start activating different cellular processes. So for example, like gene transcription. Maybe there's going to be some sort of like stimulus that wants more DNA to be made or something. You need something to happen within the neuron. And so that protein would maybe go and then activate different cellular processes. So these are the 3 different options that we would get when we have the binding of a neurotransmitter or a neuromodulator to its specific receptor. Is that okay? I know I just keep repeating it, but I just because I want to sort of hit home the 3 different options, because that's how we have one neurotransmitter or neuromodulator having different effects and small or large effects in the neurological system. So let's first talk about, in more detail, the direct activation of ion channels. So remember, with fast-acting transmission, we have a neurotransmitter binding to a receptor, and that takes about 1,000th of a second. And so a picture of what that would look like is right here. So here we have a receptor. This is direct activation, and the receptor is a channel. It binds specifically to this molecule right here, and when it binds, we can see that, in this case, it's acetylcholine. When the acetylcholine binds to the acetylcholine receptor, we have an opening of the channel, and it causes, in this case, an excitatory postsynaptic potential. GABA, which is the main fast-acting inhibitory neurotransmitter of our neurological system, that's in a diagram here. So we can see binding of GABA with the GABA receptor causes opening of the channel. And depending on what the ion is specific for, in this case, it's specific to chlorine. So once it opens, chlorine, which is negative, enters the neuron, and it causes a hyperpolarization. So it's an inhibitory postsynaptic potential. Does that everyone make sense? So it's the receptor that will dictate what the response is. When we have indirect activation, it involves the use of a protein being released by the channel, or sorry, being released by the receptor, and that protein is called a G protein. It's a global name for it. And the reason why your body would want to do that is because having the protein released means that it has an opportunity to affect multiple different areas in the neuron. So with a indirect activation of ion channels, that was the second option. We have an example of what that would look like in this diagram here. Here we have a neurotransmitter binding to the receptor. And in this case, the receptor isn't a channel. Once it binds, it releases a G protein. And you see that the G protein floats around and then will open channels. So in this case, what would happen is that the G protein would bind, open a channel, and then continue binding with channels in the other areas, or in the surrounding area, and open multiple channels. So it's a slow-acting transmission because it takes a longer amount of time. We said in the previous slides about 1/10 of a second. However, instead of one channel, it could be multiple, like 10 or 20. And then the third option is when we have the G protein interacting with different cellular processes to change like the cell's metabolism or change or cause an effect in the neuron itself. And typically that's as a result of second messenger systems. Does anyone remember cyclic AMP from like grade 11 bio? So cyclic AMP is an enzyme that creates a molecule, and then that molecule is a marker for different cellular processes to upregulate. So like DNA transcription, improving cell metabolism. That's as a result of a second messenger making a molecule to have an effect on the cell itself. So an example of what that would look like is like this. So this is the third option. We have, in this, they labeled it a neuromodulator in this case, right? Just a molecule, binds with a receptor. And in this case, the G protein is released, but it's not interacting with a channel, it's interacting with an enzyme. And then it causes this enzyme, it's adenylyl cyclase, it's causing cyclic AMP to be created. And then that cyclic AMP is a marker for the neuron. It binds with different areas to upregulate metabolism. So in that sense, we have the binding of a neurotransmitter with a receptor can cause three different processes. It can cause direct activation of a channel, fast. It can cause indirect activation of channels, which are slow and more profound, or it can activate second messenger systems and affect cell metabolism. Things that require G proteins take longer, but they have more profound effects. Things that affect the receptor that it's a channel or direct activation is much quicker. Any questions about that? Anyone? Perfect. Okay. So let's continue on. So now we're going to identify some specific neurotransmitters or neuromodulators that are like typical in the neurological system. So that way it'll help you sort of hopefully understand, because it's a lot of the things that you've sort of, or words that you've seen before. So let's first talk about, I think there's 8 of them. Let's first talk about acetylcholine. Has anyone ever heard of that before? Yeah, yep. So I brought it up first because typically, we've taken it in A&P and then like a little bio in grade 12. Acetylcholine is the main neurotransmitter of the neuromuscular junction. So neuron to muscle, right? That responds, or that synapse utilizes acetylcholine. So it's the major neurotransmitter of the peripheral nervous system, and it's utilized at the neuromuscular junction to generate a membrane potential in the muscle membrane and cause activation of our muscles. So here we have an example of acetylcholine receptors that can fall into 2 different categories. So here you can see on the slide, and there's a bunch of different ones, but it's an example of we have 2 different receptors that both bind acetylcholine. So they're all going to be called acetylcholine receptors because that's the neurotransmitter or the molecule that they bind, but then they have subgroupings based on what they do. So for example, nicotinic acetylcholine receptors, they are excitatory at the neuromuscular junction and autonomic ganglia. So does anyone smoke or like vape or chew tobacco? Nicotine's a drug. And so there's some acetylcholine receptors that are called nicotinic acetylcholine receptors that bind nicotine. So like when Matt asked a question is like, can they hit multiple receptors? Typically no, but in this case, nicotine matches acetylcholine. And so it causes that sort of like high where you get that energy from like smoking a cigarette. Another example of different, so like when you get your heart rate going and when you have acetylcholine, that's a muscarinic acetylcholine receptor. In terms of diseases that utilize this or are implicated with acetylcholine, we're going to talk about myasthenia gravis at the end of the lecture, and I think it's in your tutorial as well. So acetylcholine is one example of a neurotransmitter. And in this case, we can see how the neurotransmitter binds to different, can bind to different receptors that are specific for that neurotransmitter. Glutamate is the next one. Glutamate is the main excitatory neurotransmitter of the central nervous system. And it has, based on the receptor, either a direct or indirect or ionotropic or metabotropic effect. Now, typically glutamate is involved in the long-term potentiation with learning and development. And so there was studies on if you upregulate or you take in extra glutamate, it leads to you memorizing better or learning better. So there were studies that looked into that. But because it's a main excitatory neurotransmitter of the central nervous system, we see that we have globally decreased levels of this neurotransmitter with depression. So think about glutamate as an excitatory neurotransmitter. If we don't have enough of it, things are sort of depressed or inhibited. And so they're kind of implicated in like depression. Does anyone know or familiar with epilepsy, where you have seizures? They find that people that in certain situations, people that are prone to seizures, they have increased levels of glutamate. So if glutamate is an excitatory neurotransmitter, higher levels lead to maybe situations where we have those seizures. So there's an example of 2 different sort of like conditions, depression and epilepsy, that may have a very small, like they're neurological potentially, but they have, they're as a result of sort of like a minute change in neurotransmitter levels. GABA is the main fast-acting inhibitory neurotransmitter of the neurological system. And here we have another example of 2 different types of receptors that have an effect when they bind GABA. So here we have GABA A and GABA B receptors as an example. They both bind GABA, and the effect is going to be based on what that receptor does. GABA A are ionotropic chlorine channels, so it's fast acting. And GABA A is an example of benzodiazepines or barbiturates. So has anyone ever heard of like anti-anxiety medication like lorazepam or diazepam or those are the big ones. Has anyone ever heard of those? Okay, so what those are is it's a chemical that it mimics GABA. So when you take it, it binds with GABA A receptors. Baclofen, so GABA B receptors are slow-acting GABA receptors. So it's a receptor that binds GABA, right, the neurotransmitter. However, this one is a slow-acting, so it'll cause a release of a protein and have a slower but larger effect. An example of a medication that mimics or binds with GABA B receptors is baclofen. So working in rehab, baclofen is like a main muscle relaxant. It's given to people that are having back spasms, but it's also given with people with like chronic spasticity, like CP, because it's effective. And that's an example of a drug that binds with GABA B receptors. Opioids are another example of medication that we take that mimic neurotransmitters. So has anyone ever heard of like morphine or oxys or oxycodone or Percocets, codeine? They're all derivatives that mimic opioids, so opium. These neurotransmitters, like substance P, are implicated in the perception of pain. So when we take these drugs, they affect our ability to perceive pain. So opioids are typically painkillers. So oxycodone is like is codeine, stronger. Percocet is oxy plus Tylenol. Morphine is just a more condensed version. So they're all derivatives of the same sort of chemical, or the opioid, that binds with pain receptors. I'm sure you guys have all heard about that before, right? Because especially with pain medications, right? Oxys were so overproduced because they have, when you take too much of it, it desensitizes the area, and then people were getting addicted to them. Is everyone okay? Cool. Dopamine is a example of a slow-acting inhibitory neurotransmitter, right? So we have all heard of sort of dopamine, and it's utilized in a lot of different like drugs that treat neurological things. Decreased levels of dopamine are seen in Parkinson's disease. So remember, with Parkinson's disease, we have what's like the telltale sign of Parkinson's disease? The spasms, right? And so what we see is that in the basal ganglia of people with Parkinson's disease, there's low levels of dopamine. So there's low levels of inhibition. And what happens is we get muscle rigidity and spasm. High levels of dopamine, interestingly, are noticed in people with schizophrenia. So remember, dopamine is a inhibitory neurotransmitter. So what we see in schizophrenia is, like, if you think of it like globally in the brain as like a brain condition, it's like in a dissociation of reality from what's going on. And so the difference, like parts of the brain aren't communicating with each other. And so we have an over inhibition. And that's as a result of high levels of dopamine. And we see that in schizophrenia. Dopamine is also used in motivation and thinking. It's also used as a drug for reward mechanisms. So like it's like a pat on the back. Releasing dopamine is a way to give your brain a reward for doing something or to motivate. And so dopamine is actually, it's cocaine. So cocaine mimics dopamine. And so by taking cocaine, you are sort of interacting with the reward mechanism of what dopamine can do. Other things like methamphetamines, they work at blocking dopamine. So like meth is a dopamine antagonist. Sorry, that's not true. It blocks the reuptake of dopamine. So one way that we're gonna learn at the last slide of the lecture is one way that you can increase the effect of a neurotransmitter is prevent it from being broken down. So if you stop the breaking down of that neurotransmitter, it'll continue to float around in the synaptic cleft. So meth, sorry, increases dopamine by blocking its reuptake. Everyone okay? Epinephrine, so norepinephrine is another neurotransmitter. So this is involved in the fight or flight response. Here we have an example of alpha and beta receptors. So has anyone ever heard of beta blockers? Yep, heart meds. Okay, exactly. So epinephrine is the fight or flight response, right? It gets your body primed to like run or fight or to engage. What it does is it turns on your heart rate, it turns on muscle contraction, and then decreases digestion. And that's as a result of two different receptors, both that bind epinephrine. Beta receptors are ones that are excitatory, and they're found on the cardiac muscle. So in the presence of epinephrine, it binds with the heart muscles and excites it. So if someone has high blood pressure, you want to downregulate that because in the presence of epinephrine, it's going to be too much. So beta blockers are ways to stop high blood pressure by inhibiting the activation of the heart muscle from norepinephrine. Alpha receptors are inhibitory, and they're found on the smooth muscle. So like in our gut, when we're fighting our fight or flight, our digestion turns off. It's because in those areas, we have alpha receptors for norepinephrine, and they're inhibitory. So our body releases epinephrine or norepinephrine, and then that will float around and interact with the different receptors. On the heart, turns it on. In the gut, it turns it off. Cool? And then the last one that we're going to learn about is, I think this is the last one, is serotonin. Oops. So serotonin is responsible for sort of general level of arousal. So in times where we are awake, we have high levels of serotonin. When we're sleeping, like in REM sleep, we have low levels of serotonin. So it's released in our daily schedule as a way to make us alert or sort of depressed, not depressed, low arousal level, right? So awake or sleepy. Now, high levels of serotonin are seen when we're alert, and then low levels are seen when we are in REM sleep, so in their deepest sleep. It's also seen that we have low levels of serotonin globally in people with depression and also cases of like suicide. One drug that like a street drug or whatever that you guys would be familiar with would be like Molly or MDMA. That is an example of a drug that mimics serotonin. Prozac, which is a antidepressant, that also so like remember how like Prozac used to be the thing like 5 years ago. It still kind of is popular, but it was used for depression because it makes you alert. So it, like people that are typically depressed have sort of low energy, and by taking Prozac, you're increasing the amount of serotonin in the body, which will make you more alert. So it's a way to sort of combat that. Now the problem with these drugs is that they all are either synthesized to look like or be like a neurotransmitter because they're not organic, right? Or once you digest them, it's broken down and then ends up in a molecule that looks like the neurotransmitter that it's mimicking. And so we have different drugs that will affect certain receptors in parts of the body. And so we see that, for an example, with this just slide here. That's why we have like clinical drug trials where we'll have, okay, well, this drug mimics this neurotransmitter. Let's give it to a bunch of people and see what it does, right? So in a lot of drug trials, it can have effects like you can have like situations where drug trials have proven that the drug wasn't effective for what they thought it was, but then they found out that it was great for something else. For example, like Viagra. heart medication became known that, oh, it can do other things. And so when we develop drugs, or when like different pharmacists or chemists or the health industry develop different drugs, it's important to do drug trials because it can affect different parts of the area, or sorry, different areas of the body. So it's not just like one drug has a specific effect in one area. They have to understand that, A, how it's taken in, how it's broken down, what areas of the body it can get into, and then globally, what taking this drug will have an effect. And that's sort of the downfall with taking pharmaceuticals, is that it's typically difficult to have just one effect. There's always side effects. And this is what this diagram is sort of demonstrating. Based on drugs, there can be called an antagonist or an agonist. So for example, if we take a drug that mimics or causes more epinephrine, that would be an epinephrine agonist. It's a drug that binds to a receptor to mimic its effect, or it blocks the reuptake of that neurotransmitter. So a neurotransmitter would bind and then gets broken down. If we have a drug that prevents it from being broken down so it can interact with more receptors, that would also be an agonist. An agonist is a drug that mimics or increases the effectiveness of that neurotransmitter. An antagonist would be one that you take that, like for example, like a beta blocker. It is an antagonist because it prevents the binding or use of that neurotransmitter. So drugs either are agonists, so like neurological drugs, or that mimic neurotransmitters, are either agonists or antagonists. Is everyone okay with that? So I just wanted to just briefly finish off with an example of like a pathology that affects the synapse, just because that was the topic of the module this week. So an example of a neurological disease that affects the synapse is myasthenia gravis, or MG. Has anyone ever had it or heard of it? No one? So this is another example of an autoimmune disease. So an autoimmune disease means that your body is sort of attacking itself. And with this autoimmune disease, we have the neurological system attacking its own acetylcholine receptors. And acetylcholine receptors are implicated in the contraction of our muscles. So when we have a loss of acetylcholine receptors, what is that typically going to lead in then? If we have, okay, good. So you guys did it in the last tutorial, right? Okay. So then you guys are familiar with it. So it would lead to just problems with muscle contraction. And so what we see is in areas where, like typically the presentation of myasthenia gravis is in areas where we have fine control. So like your face, right? Hands and face, you have weakness. And so people present with sort of weakness in the areas that require fine control. So I have a video here that we can watch really briefly depicting, if you guys want to, or you guys want to watch it on your own time? Yes, watch it? Okay. Let's watch. Okay. I got to share my whole screen though, so let's do that. How do I do this? Can you guys see the whole screen now? Okay. So if I play this, can you hear it?
It's the 19th of December 2013.
I'm just going to pause it so I can look at the chat. You guys heard that? Boom. Okay. Let's continue. So here we have an example of a typical MG patient. So we'll just listen to what sort of like her experiences with the disease. And remember, with all diseases, there's some that are affected a lot and some that are affected little.
Lara is going to describe the symptoms of myasthenia she's experiencing today. I will run through them very quickly because her speech is affected and it's difficult to hear her. So the first thing she'll try and talk about is her eyes. These stop, she can't really close them very well. Then her facial muscles, especially those around her cheek, become paralysed. Her tongue also becomes progressively more paralysed. Swallowing is very weak. Neck muscles also very weak. Although this is not happening today, at times her breathing will feel slightly compromised. Okay, over to you, Lara.
Okay, so first of all, my eyes. I can't screen them up tightly and close them, particularly at night. So, for example, it's me trying my hardest to screen them up, but they're very easy to open. And just by like washing my face, things like that, I get water in my eyes quite easily. Secondly, it's my cheek muscles around here. I find it quite hard to do facial expressions because they just don't move around here. Here is my tongue, which affects my pronunciation, so it can be difficult to form. This in turn affects my swallowing, so I tend to close up my nose, and it's quite hard to swallow. Then obviously I put the nose movement around here, and it can affect
breathing. Okay, so as you can see, as Lara starts to talk, it becomes far more difficult. This is about as bad as her symptoms have got. With a few moments recovery, she's usually able to start talking again, but especially if she relaxes and she's a bit uptight, so it probably won't come back as quickly. But if you try and describe your swallowing part again now, see if that you can say.
So my swallowing gets quite weak, and I find it difficult because liquid goes up my nose. So it's words like with an N, my nose, and
right, and breathing can be affected. Right, stop again. Right, Lara has just begun pulse treatment again, which hopefully in the next few days will kick in and her symptoms will be relieved for a few weeks. So we're just starting to record this because we're going to embark on a dietary plan to see if that will help in the new year. Do you want to carry on with breathing?
I was just trying to say that some letters are hard to say. So when I say breathing, it's the B that I find most difficult. So I get pinches around my lips. So you might notice I lick my lips quite a lot. And that's because they get very dry. Because obviously they're not, the muscles aren't working. But as I rest, it's easier to say.
Okay, and just to say, these symptoms have become particularly bad because perhaps a period of stress really does impact. And also Laura's quite stressed because she's due to see her neurologist, and Laura absolutely hates hospitals, and hospitals make her very stressed, and ironically making her just far worse. Anything else you want to say?
No, I'll keep updated with how it goes.
Yeah. So we're just thinking we're going to be proactive and see if we can find lots of
window.
Oh no, it shows their face.
No, I just show my face. Jessica sometimes keeps her camera on. Everyone, this is my secretary, just behind the scenes.
Hi.
I need to send.
It's a small class.
No, it's like 160. But
Oh, is
then,
it?
yeah, not everyone comes in. Okay, so that was an example of everybody listen. That was an example of someone with myasthenia gravis, right? So you could see like the drooping of her eyelids and like the problems with talking because of the fine control or the weakness in the fine control of her face. And that's as a result of an autoimmune disease where we have your own antibodies sticking to the acetylcholine receptors in her body. And that it affects the fine control areas first, like her face. Now, they had mentioned pulse therapy in the video. Oh, 1 second. Yeah, questions. No, actually. Oh, okay, yeah. So sorry, I'm just following along on the chat. So Matt asked, can you get more acetylcholine in your body? And the problem is that it's not exactly right, Kayla. It's not that there's not enough acetylcholine. It's that there's nothing for them to bind to because you're losing receptors. And then Matt has another random question. Go. On the group chat, Matt. Oh, that was, oh, okay. Sorry, yeah. Got it. Okay, yeah. So then, no, but well, let's say there was for example, like Parkinson's disease, where it's not enough dopamine. It's not receptors. This is not enough dopamine. Then you take drugs that increase dopamine. And so the changing the diet would be to decrease inflammation. So Elena asked, what about, was it talking about diet? So the diet would be anti-inflammatory diets. Like when they said that she's going to be taking pulse therapy is when you get rapid injection of corticosteroids. Because remember, it's the inflammation, her neuroinflammation, that's causing the breakdown of those receptors. So you're taking anti-inflammatories in a sense to stop that process from happening. The other thing that the next slide, the last slide, where we talk about a thymonectomy. So your thymus helps create antibodies. So if you remove the thymus, it's like you're affecting someone's immune system. So you're decreasing the immune system. So this would be in a situation where the myasthenia gravis is so bad that it's worth the risk of not having an immune system to stop the detriment of having that disease. So by taking out the thymus, you're decreasing the immune system. Awesome. So hopefully that was all okay with the lecture. Was there anything specific that you guys didn't fully understand? I try to use a lot of examples and relate to things like in the real world to help you sort of like integrate that information. We'd mentioned last week that the previous lecture that maybe I was going too fast sometimes. How was that one? Okay, cool. Awesome. One question for Kayla. So do we need to know each of the neurotransmitters and their functions? Yeah, I would be familiar with them, but it's like just know like brief information. Because there's only 8 of them, right? So you have a fast-acting, so you have neuromuscular junction. You have fast-acting inhibitory, fast-acting excitatory, slow-acting inhibitory, pain, epinephrine. There you go. Any other questions? Okay, awesome. If you want to review your midterm, don't forget to email your TA directly. And then we don't have class next week, right? So have a really safe pandemic Thanksgiving. Stay safe. And I will see you guys in 2 weeks. Okay? Anything, email me. Awesome. Okay. Bye, guys. Elena, one more question. Will you be uploading? It takes a while to process. So as soon as it processes, then I upload it to YouTube and then send that link. So usually by the end of the day. But however long it took last time is the same amount of time. Okay, awesome. Okay, bye everyone.